It is a huge honor today to be interviewing an oral and maxillofacial surgeon who comes very well recommended by our friend Anne-Marie Gorsick. Did I say her name right?
Gorsica.
Gorsica. That sounds like that must be a Polish name. Gorsica?
That's correct.
Polish. And your name is Radhika Chigurupati. Did I get your name right?
That is correct.
That was close enough. And I was so excited to talk to you because you're talking to about 7,000 general dentists, about 85% in the United States, 15% in other 200 countries. And the rarest thing that we deal with is a patient, and we're wondering if they need orthognathic surgery. I mean, this is something that just hardly ever comes up. I mean, we do several fillings and crowns every single day and cleanings and checkups, but everything you do is so rare and foreign to us. And what I want to do is spend time with you today and talk about orthognathic surgery, recognizing facial skeletal abnormalities, everything you do. So thank you for sharing time with me today.
No problem.
So
thank you for giving me the opportunity.
Oh, thank you. So, as a general dentist, they most dentists have one or two hygienists. It's, maybe a patient every hour. What should we be thinking about when we look at someone's developing face and jaw? Is orthognathic surgery still a child development? An orthodontic issue? I mean, is it people where we're looking at their bite and wondering if this can be fixed with an orthodontist or does it need surgery? And what could we have seen when they were a child that maybe we could have intercepted or intervened on?
Sure.
You're so intelligent. I don't even know what the right questions are to ask you. So why don't So why don't you just educate all my homies on what we should be thinking about when we think of the words orthognathic surgery?
Sure. When a patient presents to the dentist, they don't usually come with problems saying, I need orthognathic surgery. They usually say they don't like their smile, or they say they don't like their bite, or they may not even reveal that they don't like their facial appearance. Most patients, unless you ask them, do not usually complain about their facial appearance in general. They usually are a bit shy. We often come across two groups of patients: the younger patients, adolescents, that present along with their parents, who come for routine evaluation to the pediatric dentist or orthodontist for correction of their bite. And then the other group of patients who are adults who may then who may present for problems related to their bite sometimes, problems related to their joint sometimes, or problems related to symptoms of obstructive sleep apnea. And all of these patients are candidates for possible orthodontic intervention sometimes, combined with surgery, or sometimes exclusively orthodontic intervention. However, it's the role of the dentist, the hygienist, and oral healthcare providers to educate our patients based on their problems.
Now, I graduated 28 years ago, and that was in '87. And I think my orthognathic surgery case lecture in ortho was like freshman year, so it was in 1984. So so what I know about this is so old in age. It was 30 years ago, but my teacher told me that all of this was caused by what he called miscentigenation. I don't even know if that's a word anymore. I don't think I've heard it since that. Basically, he said the 187 species, apes and monkeys, all have good bites and teeth, everything straight. Then the great apes, humans, gorillas, chimpanzees, orangutans, gibbons, bonobos, they're all dominant, brown hair, brown eye, class 1 molar, class 1 occlusion. And what happened was three major groups left Africa about 70,000 years ago, and they inbred one group into Europe, another group went out of Africa into Iran, up to Russia, over into North America, the North American Indians, and then a third group went to past Iran, went into China, Indonesia, Hawaii, and then to America's Inca Aztecs. And that basically, when you see someone like Jay Leno with a big lower jaw and a little upper jaw, that it was miscegenation mixed breeding back in, and he inherited like a lower jaw from like a 6 foot tall German or Russian or Pole, and an upper jaw from like a little Italian, Spanish, Portuguese woman, and that in 3 million years, just like all the apes and monkeys, we would be back to normal of all dominant brown hair, brown eye, class 1 molar, class 1 occlusion. Is that still the theory 30 years later, or is that just completely crazy?
Well, I don't know about exactly that theory, but clearly facial patterns and characteristics are inherited from our parents. So there is genetic inheritance as well as some acquired abnormalities due to what occurs during our early childhood. So if a child has a traumatic event, they could then have an acquired abnormality of the jaw. They may have fusion of the joint that may not allow the lower jaw to grow, or they may have an abnormality in the midface after a midface injury. However, most of the jaw discrepancy in size or shape may be inherited from our parents. So it's an inherited characteristic.
I'm still mad at my mother for marrying a short, fat, bald guy. Why didn't she marry?
You could also inherit one from one parent and another from another parent. So you may have a small lower jaw and a large upper jaw, or you may have a large lower jaw and a small upper jaw. So these are characteristics that you inherit primarily from your family members.
So in the last 10, 20, 30 years, is orthognathic surgery remaining steady? Is it growing in popularity, or orthodontists using it less? What's the state of orthognathic surgery today? Do the 10,000 American orthodontists still use this modality like they have 10, 20, 30 years ago? Or are they getting away from it, or are they doing it more?
I think orthognathic surgery about 50 years ago when it was born, it was not as popular. However, over the last few years, the techniques have been refined. The recovery from the surgery is much better. The fixation that we use is more rigid compared to when we used to use wire fixation. There are advances in the way we treatment plan these patients with virtual surgical planning. So there are a lot of advances. Also, there have been changes in indications for orthognathic surgery, primarily for obstructive sleep apnea now in adults. And adult orthodontics and orthognathic surgery is also becoming more popular in recent years. So these are some of the trends that have changed over the recent years compared to the last, I would say, maybe prior to 80s.
So if I was your patient, I was a 53-year-old male, and I was going to have orthognathic surgery, just the basic questions are going to ask. How much is it going to cost? How long will I miss work? And what's the chance when you're done with me, I'll be numb and won't have any feeling for the rest of my life?
I'm in an academic hospital practice setting, and I won't be able to give you the details of the cost, but I can tell you roughly it would be at least for each jaw surgery, depending on what the insurance pays. Most practices in academic practice accept insurance. It would be about $2,500 for maxillary jaw surgery and another $2,500 for the lower jaw surgery. Now, this can vary anywhere from $2,500 to $10,000 depending on the practice, depending on the type of institution, depending on the insurance. But the vast majority of patients in academic teaching hospitals are covered by some healthcare provider or an insurance.
So that's basically the same cost as any elective surgery. A facelift is on average about $5,000, but can vary to $25,000. Breast augmentation is about $5,000, but can vary all the way to $20,000. So this is basically in the range of any popular cosmetic surgery.
Yeah, I mean, it can vary depending on the number of osteotomies, the type of osteotomy, the complexity of the surgery. So there are different levels of that, but the range is approximately correct.
So how long am I going to miss work, and what's the chance of paresthesia?
So the biggest risk with this surgery, let me go back to the question on how long you're going to miss work. The approximate recovery time for orthognathic surgery is approximately 3 to 4 weeks. The first 2 weeks are really the most difficult weeks for the patient. They usually do well, the younger patients, better than older patients. And
And why is that?
I think the older patients, their lifestyle is different. They have more pain, more discomfort. Their healing time is a little longer. Overall, they're probably wanting to return to work faster and feeling a bit more restless, wanting to go back to their regular dietary habits. And in general, tissues in younger patients heal faster. So the average time is about 2 to 3 weeks. I tell the patients who have slightly increased length of surgical time or increased complexity of surgery, they may need up to 4 weeks. But in general, patients should take at least 2 to 3 weeks off after the surgical procedure. I think the younger patients usually are back to normal routine by about 2 weeks. I just saw my patient who came back at the end of 2 weeks, and he's ready to roll and get back to work.
And then what about the paresthesia? That seems to be the big question. I mean, people are always afraid.
The biggest risk with this procedure is the paresthesia. This is particularly important in the lower lip. The lower jawbone has a nerve that runs through within the jawbone, and the way the osteotomies, which means the way the bone is cut, depends on where the nerve lies relative to the outer cortex and the inner cortex of the mandible. So there is a high incidence of bruising of the nerve when we make the osteotomies in the mandible. There is some stretch of the nerve also in the upper jaw, depending on how high the level of the osteotomy is for the maxilla. However, the recovery in the maxilla is much faster, as we don't actually intervene or do not make the cut very close to the nerve. It's usually a stretch injury a little bit when we are making the osteotomy. Whereas in the lower jaw, the nerve is within the jawbone and it is within the lines of the osteotomy. So often the nerve gets bruised a little bit more, and they do have paresthesia. And in some cases, in older individuals, there is a higher risk of recovery of the sensation for longer periods of time compared to younger adults.
And how long does it actually take you, an oral surgeon, to do an osteotomy for a maxilla or a mandible? I mean, how long of a surgery is that?
It can vary depending on the experience of the surgeon, depending on the complexity of the surgery, anywhere from 90 minutes to 5 hours. So when I talk about one jaw surgery can be up to 90 minutes, and two jaw surgery can be up to 3.5 hours. And more experienced and faster surgeon may finish it in 3 hours, whereas the less experienced and surgeon who is teaching may take a little longer, up to 5 hours for two jaw surgery.
So for you personally, is that exhausting? I mean, when you're in there for 3 hours or more, or it gets complicated, you're in there 5 hours, when you're done, do you just feel like you were ran over by a bus?
No, not at all.
Really?
It can be exhausting when things are not going right. But it's a pleasure to take care of patients, and I enjoy what I do. I do enjoy teaching the residents while doing this surgery. And sometimes there are more difficult patients where patients are a little bit more obese, where the jaw is more retruded, patients with obstructive sleep apnea, patients with clefts. The orthognathic surgery is more complicated. There's more scar tissue in some of these patients, and the surgery can be more complex and it can be tiring.
So are you ever working up a patient, say you're 30, they're done growing, say they're 21 and over. Are you ever looking at this case and thinking to yourself, well, this is kind of sad, because if the general dentist would have done, referred to an orthodontist or did this when the child was still developing his arches, none of this would have happened? How often do you think that is the case, that the general dentist is kind of asleep behind the wheel, didn't recognize what was going on, didn't get it referred to a pediatric dentist or an orthodontist where they could have expanded the upper jaw with a rapid palatal expander or something like to that effect?
I think I occasionally see those patients, but it's not that anything cannot be done. So the real problem is when something is done where they actually take out the teeth when surgery would have been appropriate, and then you cannot undo what was done previously. It's okay if nothing is done and the patient arrives at your office much later, at a later date, and we can offer them the options even at a later date. However, there are times when people try to compromise the skeletal deformity by correcting it dentally, which then compromises the results. The skeletal abnormality is not treated, and here you're left with limited options for the patient, which should have been corrected both skeletally and dentally. And so it's not ideal in those situations. I think that is far more worse than not having informed the patient. I think in general it is our responsibility as oral healthcare providers to inform the patients about available treatment options for correction of obstructive sleep apnea, for correction of functional problems such as jaw joint problems, and for correction of difficulty in chewing, and also for improvement of aesthetics. And it's our responsibility to inform them that this may be a combination of dental and skeletal problems.
Okay, for your level of expertise, a board certified oral and maxillofacial surgeon, teacher, all your credentials, can you spot the skeletal abnormalities just by looking at someone, or do you need to be looking at a SAF or a pano? I mean, can you educate 7,000 general dentists how they can quicker, identify skeletal abnormalities?
Yeah, I think facial appearance tells us a lot. When you look at a patient, you look at them in thirds. There are the golden proportions of the upper third, the middle third, and the lower third being proportionate. You can look at some hollowing in the infraorbital region below the eye. You can look at the area of the cheekbones. You can look at facial width. You can look at the area around the nose to see if the nasolabial folds are deep. You can look at the upper lip support to see their smile line, to see how much of their teeth are displayed when they smile. As we age, we show less of our upper teeth. Our nasolabial folds become deep. We also have difficulty in bringing our lips together sometimes when there is mentalis strain and our jaw is retruded and our chin is retruded. So these are some of the signs to look for to look at skeletal abnormalities.
Now, the most common, besides a bite wing or a periapical, probably the most common x-ray everyone listening to you looks at bigger than a tooth would just be a pano. Can you really see any skeletal abnormalities on a pano?
You can see some. A panoramic radiograph is a good screening tool, but you will not be able to fully use only exclusively a panoramic radiograph to make a full diagnosis. But it's definitely a screening tool if you're suspecting any excessive jaw growth abnormalities or temporomandibular joint or ramus or body of the mandible if you want to look at abnormalities in this area.
I've been out long enough where, practicing 30 years, sometimes things come out in dentistry and they turn out to be a fad, like maybe microabrasion. It was all the rage and then it faded away. When I got out of school, they had these yag that were $50,000. They sold like 1,000 when out of business. It seems like with sleep apnea, like you never heard of it from like 1980 to 1990, never heard of it. 1990 to 2000, never heard of it. And then all of a sudden, about 5 years ago, my God, you can't read anything in dentistry without seeing 3 articles on sleep apnea. So, is this a fad? Is it overblown? What's the reality of sleep apnea, and how much of this? Just tell us all your thoughts on sleep apnea.
Well, I think maybe there is an increase in awareness in the last few years about obstructive sleep apnea.
There,
The
there, there,
problem
there,
may,
there was a lady on, gosh, who's the lady who just sold the Huffington Post, Ariana
yeah,
Huffington.
Huffington.
She was on Bill Maher saying that the reason Bill Clinton had an affair with Monica Lewinsky is because of sleep apnea, and he wasn't getting enough sleep, and he was being irrational and making bad decisions. I mean, it's just like it seems like on the internet, it's just a cure for everything. Weight loss, you're not sleeping enough. Just everything is cured by sleep apnea. So I'm sure it's going to come back a little.
Yeah, I think maybe it's a little overrated, but definitely there is more awareness about the importance of sleep for memory, for functional tasks, as well as for daily performance. So I think that maybe both in the dental and the medical field, physicians are recognizing that people with comorbid factors, there is a correlation between people with cardiovascular disease, hypertension, sleep apnea, and stroke. So there is increased awareness. However, I don't think everything can be said to be related to sleep apnea.
So how are you screening for sleep apnea, and when is surgery part of the solution for sleep apnea as opposed to like a CPAP or a dental retainer?
Sure. So patients present with symptoms of sleep apnea. You can also look at some of the skeletal facial features and see if these patients have some of the features that may be causing them to their sleep apnea. It's a continuum of a problem from snoring. Snoring does not necessarily mean a patient has sleep apnea. The patient may have snoring as a problem, but they may not have obstructive sleep apnea. So it's important to differentiate between the two. Patients have facial characteristic signs, but not all patients with those facial characteristics will have sleep apnea. In general, males above the age of 40 or 45 are at a higher risk. Patients who have other comorbid factors with hypertension, increased neck girth, they are smokers and alcohol users, and who are males above the age of 45, you can screen them and ask them questions about whether they snore at night, whether there are witnessed apneic episodes. If they sleep with a partner, the partner may notice that they stop breathing and gasp for air, and this may happen quite frequently. They may feel increased daytime somnolence or weariness. They may fall asleep frequently when they are driving or performing their daily tasks. These are some of the questions you can ask patients who you think are at a higher risk. As I mentioned earlier, the increased risk factors are males above the age of 45, increased neck girth, smokers and alcohol users, and also patients who have different irregular sleep hours because of their work.
Now, do you recommend when a dentist is seeing a patient on recall and it's a older fat male like myself to just whip out a tape measure and go around the neck? I mean, are you looking for an inch? Like what is it, 16 and a half or greater? Or
18 inches or greater.
18 inches or greater?
I don't usually measure with the tape, but you can tell the physical appearance.
Okay,
and
just by looking at me, I'll move my microphone.
An objective assessment, I do ask them their collar size sometimes, and I will do a tape measurement when I'm truly doing an assessment of a patient. I do check their blood pressure. I ask them questions about witnessed apneic episodes. I ask them questions about whether they fall asleep at the wheel. These are some of the questions I ask.
So just looking at my neck, do you think it is? Do you think I'm close or not?
Well, I do think you have mild obesity.
Mild? Wow, that's the first woman that ever said mild. Usually they say it's extreme obesity and they put a sack over my head and then they say I'm going to turn off the lights to enhance your appearance. But no, I was worried about myself, and what I went down there and it gave me great peace of mind because I did the sleep study, and the guy told me the next morning, he goes, you actually sleep exceptionally well. He said you might have been the best sleeper I've had in like 2 months. Because I have the obesity thing going. I got the big neck. But so you do or don't recommend us measuring the neck if in the dental chair if we're
I don't think it is necessary. These are all factors to look for. You don't need to measure everybody, but you can ask them questions that will help you counsel them appropriately to seek care if necessary. You can ask them whether they feel like they're sleeping well, whether they're smokers, whether they've had any witnessed apneic episodes, whether they feel tired during the day, whether they drink a lot of coffee to keep themselves awake and alert.
Is the smoking and the coffee the same thing? It's just that they're abusing a stimulant, and the stimulant interrupts your sleep at night. Whereas some say you shouldn't have any coffee or any stimulants after like what 4 hours before you go to bed, or what are your
In general,
thoughts?
good sleep hygiene is recommended by all sleep specialists. And good sleep hygiene meaning you have to sleep at the same time, try to wake up at the same time, and try to keep regular hours and avoid stimulants or caffeinated products after a certain time to keep the number of hours of at least 6.5 to 7.5 hours of sleep per night.
That was the best thing that came out of sleep apnea for me. Is I went there with my two dentists that I work with, and for me personally, after I did that course, I took the television. I quit using the television in my room, and I did focus on the. I'm gonna now have a bedtime at 9:30 because I get up every morning at 5, and the room colder. I turned the ceiling fan on, but sleep hygiene was really neat for me because I never thought of sleep hygiene. I was laying there and the TV's on half the night. I have your cell phone's dinging and every time you get an email, so that was good. I couldn't ask my partner if I had any episodes because every time I asked my two cats, they just they wouldn't say anything. So I thought maybe since they're not saying anything, I should go get it checked out. When is sleep apnea need surgery versus a CPAP machine?
So a CPAP is the most effective treatment for patients with obstructive sleep apnea. And the severity of sleep apnea is graded as mild, moderate, and severe. The first device or appliance that most people recommend is CPAP. However, using CPAP is quite cumbersome for most patients, and most patients don't like using a device at night that causes them to have to put this mask on the nose and sleep on their side and have to have this machine attached to them. It's not a fun piece of device to have all night. So it's mostly compliance that makes it difficult to maintain. So therefore, they're looking for alternative therapies. However, CPAP is the most effective treatment for obstructive sleep apnea. It's when patients cannot tolerate this device.
Say again, what is the most effective after CPAP?
CPAP.
Okay.
Continuous positive airway pressure.
So when would surgery be indicated?
So we do get patients who are unable to tolerate CPAP, who have severe obstructive sleep apnea, and these are patients that may have different levels of obstruction at the level of the nasopharynx, at the level of the oropharynx, and the hypopharynx. The theory is that by moving the upper jaw and the lower jaw forward, you can affect all three levels of obstruction at the nasopharynx, oropharynx, and hypopharynx, and therefore maxillomandibular advancement can be an effective treatment modality for obstructive sleep apnea.
And is this getting, was this non-existent 10 years ago and growing more common?
No, it was existent. It was definitely a surgical modality that was advocated for patients with sleep apnea.
10 years ago?
Yes.
And are you seeing that procedure getting more common since it's sleep apnea is everywhere in the media, everywhere in social media? Everybody's talking about sleep hygiene, sleep apnea. Is this for, are you seeing more mandibular maxillary advancements through orthognathic surgery for the
I would
treatment
say
of sleep
there is
apnea?
more increased awareness, and there is evidence in the literature that bimaxillary advancement may be a treatment modality for patients with severe obstructive sleep apnea with multi-level obstruction.
You're saying bimaxillary, so just the maxillary, not the
No,
mandible.
bimaxillary meaning upper and lower jaw.
Oh, bimaxillary means upper
And lower
maxillary
jaw.
and lower mandible?
Yeah.
Oh, that seems like a weird term. Why would bimaxillary would take two maxillas, not a
You
maxilla
can
and a
also
mandible?
call it maxillomandibular advancement, which is the more common term, MMA.
MMA? Huh. They always say you should think positive, and I positively think all my patients hate their CPAP.
Yeah.
So,
But I think
what percent of
patients have
patients?
to be educated about the CPAP, and I often refer the patients back to their pulmonologists or neurologists who see them often for sleep apnea, and ask them to educate them and see if you can get a better fitting mask, better fitting device. Certainly, surgery is no fun for anybody. If there is a non-surgical option, I encourage patients to go with the non-surgical treatment option first and give it a try.
I did this volunteer missionary dental trip down in Mexico with about 10 dentists, and the guy sleeping next to me, there was like four to a room, had a CPAP, and he was telling me how 10 years ago it was this loud, noisy thing, and I mean, it looked like a CD player, and I didn't hear a thing all night, and not one person in the room said they heard it or annoyed them or anything. He said it just come a massively long way.
Uh-huh.
Is there anything that would apply more to the general dentist? Most of my audience is general dentists, but I mean, you could talk about everything. You could talk about cleft palates. I mean, you could talk about everything. Well, what do you think would be the best? We're half done. We're 30 minutes down and 28 to go. What could you utilize this half hour for to educate general dentists on things they should know more from your perspective?
I think the most important thing is, since we are on the topic of sleep apnea, is to ask patients when they see certain skeletal abnormalities. For example, in a patient where they may see that they're lying in the chair but having some difficulty with breathing through their nostrils and they're constantly sniffing, so look for enlarged inferior turbinates, look for signs of a deviated nasal septum, ask them if they have trouble breathing through their nose, look for enlarged tonsils, do a proper exam when they're in the chair, ask them if they have a spouse accompanying them, whether there are witnessed apneic episodes. In a child, to look for a narrow, high-arched palate, their mouth posture, whether they are mouth breathers. Children, especially when they are growing, if they are mouth breathers, they will have a low tongue position and the palate will remain narrow and constricted. An expansion of the palate has shown to improve symptoms of obstructive sleep apnea.
Yeah, that was a lot. Now, I'm so old. You realize when I got out of school, people with snoring problems were going to ENTs who were taking carbon dioxide, CO2 lasers, and just reaming out the back of their throat. I mean, the uvula, they just bored it all out. And I had about, I don't know, maybe 5 patients that did that from maybe 87 to 92. And every one of them was depressed because they lost so much sense of taste and smell by having the back of their throat roto-rootered out with a carbon dioxide laser. Do you remember those days, or did you remember reading that?
UPPP was a common procedure.
What was it called? Triple P?
UPPP, uvulopalato-pharyngoplasty.
Wow.
Is a common procedure. It's still, there are indications for soft tissue surgery, intrapharyngeal procedures in certain patients, which include the tongue base reduction with the radiofrequency ablation, reduction of the soft palate length to increase the tautness of the soft palate. These are all procedures. However, the indications for the procedure and selection of the patient is very important. So I think consultation with the surgeons to indicate which procedure suits the patient best is something that has to be done. And the dentist can also use oral appliances or oral devices in patients with mild and moderate sleep apnea to see if a mandibular advancement or mandibular repositioning device can help patients with obstructive sleep apnea.
I want you to switch to tonsils and adenoids, because again, going back in the 80s, when I was little and just got out of school and you look down a child's throat and they had, tonsils the size of ping pong balls and you sent them to the ENT, they just whacked them out every time. And I would say that was in the 80s. I'd say by the end of the 90s, by 2000, you almost couldn't get an ENT to remove tonsils and adenoids. Talk to us about tonsils and adenoids. Are you aware of that shift from a long time ago to now where they were, I would say they were almost routinely removed in the 60s and 70s. I mean, if in doubt, you just remove the tonsils adenoids. And then it's shifted all the way over to, I really need a really good reason to remove these. So what should a dentist be thinking about with sleep apnea or a child with tonsils and adenoids?
I think it's up to the dentist to at least look at the airway, and determine if they have enlarged tonsils. Ask the parent about symptoms of snoring, about symptoms of witnessed apneic episodes, and symptoms of frequent upper respiratory tract infection. If all three of these are present, then the child should be referred to a pediatric otolaryngologist for further consultation if they do have symptoms of sleep apnea or they have very frequent upper respiratory tract infection with enlarged tonsils and symptoms of tonsillitis. So examining the airway is important. And not every child gets their tonsils and adenoids removed these days like they used to in the past, but at least the pediatric otolaryngologist, who is the expert in the area, can counsel the parent appropriately then. Or the primary care physician also is in a better position to appropriately counsel the patient and refer them to a specialist if needed.
And when you have a patient that has, mild, moderate sleep apnea symptoms, and I know it's a comorbidity and you're looking at this full spectrum, but they definitely have a deviated septum. They had difficulty breathing through their nose. How big of a factor is that in getting the deviated septum fixed for breathing?
Well, it's not an exclusively one factor that causes this. So the first thing is to do an objective assessment of the airway, the nasopharynx, which may have to be done both by direct clinical examination and endoscopic clinical examination to determine the level of obstruction. If it is very severe and they are only breathing through one nostril, then it should be appropriately corrected. Enlarged turbinates in patients who have frequent allergic rhinitis symptoms and extremely deviated septum can cause moderate obstruction of the nasopharynx and the nasal passages. You can see these signs by use of accessory muscles when their nostrils flare, when they're inhaling and exhaling. These are some of the signs that you look for to see on clinical examination. But using an endoscope will give you a much better perspective of the evaluation of the nose. And the dentist may not be able to do this in his office, but the otolaryngologist can certainly do this with a speculum and endoscope.
Have you ever thought about changing your name to Dr. Dental Wikipedia?
No.
Man, those words flowing off your mouth, I can't even Google them fast enough to figure out what all the terms you're saying. They just flow from you. So what else should they know? What else should dentists know? I'm not even smart enough to ask you questions. We're 40 minutes down. I only get you for 20 more minutes. But I want to ask you for this. This is what I want to beg you from. We started Dental Town in 1998, and I thought it'd be a couple hundred dentists on an internet study club. And we signed up 1,000 a month since 1998. We have 205,000 dentists from every single country on earth. And we put up 350 online courses, and they've been viewed over 500,000 times. And what makes it the most romantic to me is okay, so it helps Americans, Canadians, Australians, rich countries, Germany, Scandinavia, it helps those dentists be a little better. But when you go to dental schools in Africa and Asia and South America, it's their entire curriculum. And we have never had an oral surgeon like yourself make a case, all this, that would probably be better if it was, slides or whatever. Would you ever consider creating an online CE course for Dentaltown on all this amazing stuff that you know?
Yeah, I'd be happy to.
Oh
Yeah.
my God. Because when I go to some of these dental schools in Asia, I mean, I walked into a dental school in Kathmandu, and the
Yeah.
dean of the dental school, she started crying because she's like, "Oh my God, it's everything, it's free."
I'd be happy to educate
Oh,
online anytime.
and there's so many private dental schools popping up all over Brazil and India and Africa, and their curriculum. I mean, they don't even have a textbook. It's all internet, YouTube, and Dentaltown has, a nice. It's really becoming the first online dental school, and a lot of what you're saying, it would really help if you saw a slide or something about what you're talking
Yeah,
about.
no, I'd
But
be more than glad to help.
it would be the greatest honor to capture your amazing mind and see this all on a CE course. But hey, thank you for all that you do. A big shout out to Anne Marie Gorchek. Am I saying it right?
Corsica.
Gorsica. Huh. I always call her Anne. So I never say Gorsica. So a big shout out to
Thank you for giving
Anne.
me the opportunity. I would love to educate other dentists and other specialists online anytime.
Well, just send me. I'm Howard at dentaltown.com, and it's Howard Goldstein's in charge of online CE. So his email is Hogo, Hogo, at
Okay.
Dentaltown, Hogo at Dentaltown. But email me, Howard at Dentaltown, and CC Hogo at Dentaltown. But you're like, there's 2 million dentists on Earth, and you're one of 3 people probably on the planet that could talk at this level about everything you're talking about.
There are plenty who can talk, but I'm happy to give my time.
Okay, well, thank you very much
There
for
are
all that you
many
do.
maxillofacial surgeons who are experts in what I do and more than experts than me. So I think I'm available to do this, and I'll be more than glad to do it.
Anne Marie told me that you were the smartest one on earth in this field. She said that, and I believe her over your humility and humbleness. So have a good flight, and I look forward to doing this again on facial abnormalities, cleft palates, and I would kill to have an online course at any length you want. It could be an hour, it could be 6 hours, whatever you think it takes.
Okay,
And
that's
just
great.
remember when you're preparing it for many dental schools in Africa, Asia, and
Absolutely.
and Latin America, it'll be the only curriculum they get. So
Yeah, as long as I don't share patient information or photos that violate HIPAA, I will put all the educational material together and I will review it and send it to you.
or what you could do is you could Photoshop my face on those patients, and then they'll just all think it was me, and I'll sign a release.
Okay.
All right, have a great day.
You too.
Bye-bye.
You too. Bye-bye.